Let's turn now to the lung. Pulmonary toxicity. The lung, like the brain, also exhibits a hyperbolic function. That is to say, the asymptote lies at about 50%, or 0.5 ATA. So we could breathe pure oxygen at 50% for almost an indefinite period of time. The clinical manifestations of pulmonary toxicity would be the following: substernal pain, tracheobronchitis, and dyspnea, that is, shortness of breath. If we were to look at the physiology that underlies these manifestations, we'd find there's a reduction in mucus velocity, reduced lung compliance, reduction in vital capacity, and an overall reduction in diffusion. If you biopsied the lung to look at the histology behind the physiology, you'd find that there is alveolar edema, hyaline membrane formation, lysis of the very thin type 1 cells, and its replacement by the thick cuboidal type 2. The bottom line is a picture very reminiscent of interstitial fibrosis. Finally, let's turn to HBO and the eye. In this category, there are a number of phenomena you should be aware of. One is that patients can develop a progressive myopia. Now, this is a reversible phenomena, but in clinical practice, what you might find is a patient who says, I'm having difficulty driving here for my hyperbaric therapy. Those street signs at a distance are becoming a little blurry. If that's the case, we simply would reassure the patient that this is a short-term effect and it will typically resolve itself. On the other hand, if they're complaining of reading a book, well, that would be an unexpected change. There can also be exacerbation of cataracts, as you'll notice in bullet 2. Now, this only occurs for patients who have existing cataracts. That is to say, HBO is not cataractogenic. The only reported cases might be for patients getting HBO and getting very large amounts of radiation. This would perhaps be for people coming out of the hyperbaric chamber and getting CAT scans. And then finally, there's this category of retrolental fibroplasia. Weren't there these little babies back in the 70s and 60s who were rendered blind from too much oxygen? Well, that's what people thought, but today we know that that really is a nonspecific stress response. That is to say that a very young newborn is under stress, people gave them oxygen, and some developed retrolental fibroplasia. What happened is people attributed a cause-effect to what was merely a correlation. Recent meta-analyses have shown that retrolental fibroplasia occurs whether or not you get oxygen. So one has nothing to do with the other. But the clinical importance nonetheless remains. So should you be called to consult on a family of 4 for carbon monoxide poisoning, and suddenly somebody says, here, we have this 3-week-old baby, I would proceed very comfortably giving that child hyperbaric oxygen with no concerns that we're going to, render them blind through this retrolental fibroplasia. Again, a concept that many people believe is related to oxygen, we now know is simply a nonspecific stress response. So what are the potentiating factors? Are there some things that could increase your risk beyond the baseline we looked at earlier? Well, yes, there are. It would include things such as the following: hyperthermia, elevated temperature. Most programs will provide mandatory air breaks for patients who have fevers because we recognize that carries with it an increased risk. And perhaps one of the easiest ways to think about this is the recognition that young children can have febrile seizures. Most people in medical practice recognize that. So I find it easy to remember this. It's kind of like the febrile seizures that children have, only adults now have them. And the only way you can have it as an adult is to breathe pure oxygen. Now, there are other potentiating factors, such as hyperthyroidism. If you think about it, you're in a hypermetabolic state, so this, of course, would increase your risk. Elevated PCO2 or hypercapnia. We know that that is a vasodilator. Some of you that take care of head-injured patients know that mild hyperventilation will help to vasoconstrict and reduce intracranial pressure. Acidosis has been cited as a potentiating factor. Brain trauma or ischemia, that certainly makes sense. Patients with pre-existing seizures, hypoglycemia, and vitamin E deficiency. So who is vitamin E deficient? Well, that syndrome is certainly difficult to identify, but I can tell you who is at risk. Many of the patients that would come into a wound healing center. Who do you have? Elderly patients with mobility problems. It's difficult to go to the grocery store and to have a well-balanced diet. And existing as many of these people do on RC Colas and Frito-Lay, it's easy to drift into a state of nutritional oblivion. So I find, just as a practical standpoint, it's easier to just give vitamin E on an empiric basis to all of my patients. Typical dose is 400 units once a day. Now, it is possible to measure vitamin E levels. You would ask for alpha tocopherol levels. Many hospitals actually run this. You may say, well, who's getting these? Well, that would be the neonatologist. There can be some vitamin E deficiency syndromes in newborns. But as I say, on a practical basis, it's probably far easier to provide this empirically. Now, you should be aware that there have been meta-analyses looking at vitamin E used for aging, etc. One was recently published in the Annals of Internal Medicine, where the authors expressed concern of side effects. But these side effects were only noted at higher doses, 800 units and higher. For 400, there really was no significant side effects, and our patients are clearly under an oxidative stress. So again, this is something that might be prudent to consider. Other potentiating factors: vasodilators, insulin, carbonic anhydrase inhibitors. This would be a medication like a Dimox. Now, the Dimox that most people run across in practice is usually topical Dimox for the management of glaucoma. Certainly that doesn't pose a significant concern. However, there is an indication for hyperbaric therapy that some of you may be called upon, and that is central retinal artery occlusion. With these patients with central retinal artery occlusion, what oftentimes happens is they have sudden blindness of the eye. They're seen by an ophthalmologist. Many of them do oculocentesis, that is to withdraw some of the fluid from the eye to presumably increase the blood flow. At the same time, they may give these patients a very large dose of Dimox, carbonic anhydrase inhibitor. Now, earlier we talked about carbonic anhydrase and the important role it plays in physiology, solubilizing carbon dioxide. By blocking this enzyme, you're able to elevate the CO2 levels in the body. And the result of this is to vasodilate the central retinal artery, further improving the perfusion under this catastrophic circumstance. Then the very next thing they may do is they turn to you. Having a hyperbaric unit, you have the ability to superload the bloodstream with large amounts of oxygen and possibly salvage some of the compromised retina via collateral flow. Now, in the meantime, the central retinal artery may open up and you may find a striking improvement in your patient because you've preserved that retina during the critical time frame of ischemia. Now, having said this, all I can comment is that I have had considerable case experience, as others, that providing HBO with carbonic anhydrase inhibitors on board full dosing does not pose a dramatic or serious risk. Nonetheless, it might be prudent certainly to provide air brakes, and we'll even talk about medications if that might be required. Now, continuing here on our list, we have sulfamylon. You may read in various textbooks authors expressing concern about sulfamylon because if it's absorbed through the tissue, it has a carbonic anhydrase effect. Sulfamylon is an antibiotic cream. It's not used too often in general practice, but is used in some burn centers. And thermal burns in particular denude large areas of the skin, massive body surface that can precisely lead to significant absorption. Then we have epinephrine and norepinephrine. Now, are we talking about patients on Levophed drip? Absolutely not. What you need to keep in mind here is that patients who are worried or under stress due to pain or a recent debridement of their foot, or just have anxiety, confinement anxiety. We'll talk more about that later. That with that pain, with that anxiety, comes what? Well, the release of catecholamines. It's the old fight or flight. When I'm anxious, what happens? Well, my hands get sweaty, my heart starts to race and get palpitations. And this, of course, is simply the physiologic reflection of the release of epinephrine and norepinephrine. So in the hyperbaric environment, it's important that we keep our patients very calm and very relaxed. That is precisely what allows them to tolerate these very high oxygen pressures. And then we have this final note here on steroids. There are some concerns about steroids. All I can say, again drawing on my experience and others, is that steroids in the typical dose, that is to say the dose that's commonly used for patients with asthma, rheumatoid arthritis, 20 to 40 milligrams of prednisone a day, doesn't pose any significant or striking increase in risk. Now, if your patient is getting a very, very high dose, again, it would be wise to proceed with caution. Again, these are simply potentiating factors. They're not contraindications by any means. So are there protective factors? That is to say, are there some things that could reduce our risk of oxygen toxicity? Well, one would be vitamin E, but only if you're vitamin E deficient. We know from animal studies that if you give animals large doses of vitamin E, pushing them to supernormal levels, this doesn't offer any protection beyond a baseline value. So only if you're vitamin E deficient will vitamin E be of any benefit. The next one would be hypothermia. We certainly don't make our patients hypothermic, but what we do is aggressively treat any fever. As we've noted before, elevated temperatures carry a risk, so we want to do everything we can to reduce those temperatures. And then we have this concept of intermittent exposure, that is, air breaks. We've referenced air breaks elsewhere in the curriculum, and now would be a good time to really talk about air breaks in great detail. If you are in a monoplace chamber, you of course are compressing with pure oxygen. And we must periodically have the patient actually pick up a mask and go to air. In contrast, in a multiplace, they compress on air and then they use the mask to deliver therapeutic oxygen. So in a multiplace, an air break is achieved in the reverse fashion. They simply discontinue the mask or discontinue the head tent. But in either way, you're giving a patient a momentary break in their exposure to oxygen. So let's look at how air breaks could be delivered in a monoplace system. Typically what you'll find is that most programs will provide mandatory air breaks at 2.5 ATA and above. As we saw earlier, exposures at 2 ATA are very close to the asymptote. That is to say, you could breathe 2 ATA for many hours without risk of CNS effects. But as soon as you go to a higher pressure, there is this risk. People would also recommend the use of air breaks anytime the patient is running a fever. Again, many programs will usually adopt this as a policy for temperatures greater than 100. And certainly some of your patients have a good reason to have a fever. For example, they may have anaerobic infections or osteomyelitis. And the third indication typically, or the method for providing this, again for many monoplace centers, is on what's called a 30-10 schedule. We'll talk more about these air break schedules, but 30-10 means that you would have 30 minutes of oxygen, followed by 10 of air, followed by 30 of oxygen, and 10 of air. So we'll talk a little bit more about protocols later. Now, in a multiplace, what you oftentimes find is that they use shorter air break schedules, but there's reasons for that. Their staff in the chamber is breathing air continuously, and every additional minute in that chamber poses an additional risk to the tender. Now, at 2 ATA, what you will find, again, these are general sort of approaches, is that if an air break is required, it can either be delivered on a 30-10 schedule or a 45-minute of oxygen and 10 of air schedule. So how exactly does one provide air brakes in monoplace systems? Well, there are a variety of ways in which they can be set up, but at this point in your training, it would probably be useful to look at the general concept. You have an air cylinder. It has a universal gas code marking of being yellow and white. All gas cylinders must be universally marked in accordance with the Compressed Gas Association, or CGA. Certainly we recognize that oxygen is a green cylinder and air is yellow with a white top. And at the top of these high pressurized H cylinders, as they're oftentimes called, there are two gauges, and there is a step down regulator. The step down is reducing the very high pressure of 2,000 to 3,000 pounds per square inch gauge down to a more usable pressure on the order of 50 to 100 pounds. This line then goes into the chamber, and here there are a variety of masks that exist on the market. For example, in the upper left is what's called a free flow mask. Then in the upper right we have what's called a Scott mask, or a demand valve mask. With a Scott mask you have to have an extremely tight fit on the face because it will not work unless you have a complete seal. As the patient begins to inspire, you have a slightly negative pressure that triggers a demand valve. It functions very much like a scuba regulator, and if any of you are scuba divers, you probably know that familiar kick you get with each inspiration. Then, of course, in the lower left there, we have a trach mask, and on the lower right, we have what's called a face tent. Now, the trach mask you see here could be useful for your trach patients. Certainly a face mask does not work well for them. And it's even possible to provide air brakes with hyperbaric ventilators. We'll have a technical session later. It is possible to actually have patients on ventilators and to treat them safely in a monoplace chamber. But the hyperbaric ventilator draws gas from within the chamber. So what you're looking at here, just to orient you, is the inside of a monoplace chamber door. And you have the delivery module at the top, and the red circle is highlighting the intake for the ventilator. Now, Lynn Weaver and others have discussed how these ventilators can be modified, but you'll notice in that black anesthesia bag there are two lines coming in. One is a green line and the other one is a yellow line. And what is done is you make a little incision in the side of the bag. You drop an oxygen line and an air line in there. Now, if we have just oxygen flowing into the bag, then the ventilator, by necessity, is just delivering oxygen to the patient. If we switch the valve to air and we fill the bag with air, now the ventilator will only deliver air to the patient. This will be referenced certainly in some of your materials. You can look elsewhere as to how this can be modified. Now, how effective are air brakes? Well, here is a study that really speaks to the effectiveness. What the authors are doing is they're looking at the decline in vital capacity of the lung with exposure to oxygen. The lung is an organ that lends itself to easy study because we can do pulmonary functions. The brain, in contrast, is considerably more complex. And we find that in this particular study, breathing continuous oxygen, that at 6 hours of continuous exposure, there's about a 5% decrease in vital capacity. In contrast, if we provide air brakes on a 25 schedule, that is to say, 20 minutes of oxygen and 5 of normoxia, we have more than doubled the exposure. Now, in looking at this study, you may say, is this really apples to apples? The increase in time includes not only oxygen time, but also air brake time. So if we adjust it to just compare oxygen time to oxygen time, you still find a very favorable difference. Here's a comparison of O2 to O2, and you see that you still more than double the difference. Now I'd like to pause here a minute to discuss a few things on this matter of air brakes. One of them deals with this difference of 5 minutes versus 10-minute school of thought. And here's what's important for those of you that are new to hyperbaric medicine, is to understand that everybody agrees air brakes are effective. And everybody agrees that there are certain scenarios or circumstances where air brakes should be provided. Where you may discover some disagreement or certainly lively discussion is on the matter of 5-minute versus 10 minutes. It would be useful for you perhaps to understand where all this came from. Most of the work done on oxygen toxicity is really the product of the Department of Defense, coming out of places like the Experimental Dive Unit in Panama City, where the Navy is specifically looking at how long people can be exposed to oxygen. So who are they studying? Well, they're typically studying young naval recruits in the prime of health and deliberately exposing them to oxygen, inducing these problems of oxygen toxicity and seizures. Who do we have in clinical practice? Well, we have aged patients with a whole variety of comorbidities. So I don't know that it's necessarily a fair comparison to look at the results of a very young, healthy population and extrapolate that to an older population, some of whom have had perhaps subclinical strokes, like lacunar strokes and so on. So people that subscribe to the 10-minute school of thought feel that it's better to err on the side of caution. Now, in contrast, if you're running a multiplace, then it really is a race against the clock, because every additional minute in a multiplace exposes an additional risk of another problem, decompression sickness. Now, we'll talk more about decompression elsewhere in the curriculum, but at this point understand that because the tender is breathing air, every additional minute adds to the risk of nitrogen buildup and decompression sickness. So many times what you find is in multiplace operations, they subscribe to a 5-minute air brake, whereas in monoplace, we don't have this concern or risk of a tender in the chamber. There's only the patient. So many multiplace operations simply err to the side of 10 minutes with the added caution and benefit, and of course they are not having to run this race against the clock. So perhaps this may help some of you as you go to national meetings and you hear discussions of 5 minutes versus 10 minutes, that it's not to say that any school is particularly right or wrong, but there are a number of factors to consider, and all of them agree that air brakes clearly are effective. This brings us to the question of medications. Air brakes are really perhaps the most effective means to prevent oxygen toxicity. Clearly cost effective, there's no additional cost, and certainly no side effects. But the topic of medications here is really one of the things that I think the MDs in our audience will be more interested in. So for the technicians and nurses, you're certainly invited to follow along here in the discussion. But the physician at some point may decide that there is significant risk for the patient. It would include some of the risk factors we talked of. How about that elderly patient that's had a stroke, a CVA? They've had pretty good recovery, but you know that that would be an example of brain injury. How about somebody that's had a metal plate? How about somebody that's got a seizure disorder? A known risk factor. Would air brakes be adequate and sufficient? Maybe, maybe not. So if you're looking for an additional layer of protection, you could consider medical management. Now, the specific medications that would be of benefit are 3. Phenobarbital is really thought to be perhaps one of the most effective agents. If you're giving a rapid load, you of course have to be mindful of respiratory depressions. But beyond that, phenobarb does pose some other clinical considerations. At a minimum, you're going to have to establish stable blood levels. You'll also have to be mindful of the fact that phenobarb is an inducer of the P450 system. So if your patient is being anticoagulated with Coumadin, you're going to have to check the INRs. And we now begin to realize that there's a whole nother level of complexity in using a medication like phenobarbital. In contrast, if we consider medications like Valium, these certainly are a lot easier to provide. An effective dose for Valium is 5 to 10 milligrams. Now, if you're using Valium for anxiety, be advised dosages larger than normal may be required. This will become very important when we talk about confinement anxiety later. But at this point, if we're simply concerned about preventing the risk of an oxygen seizure, then either 5 or 10 milligrams will suffice. Now, a common question, who gets 5, who gets 10? That's largely a matter of experience. But if you have, for example, a frail elderly lady who weighs only 105 pounds, she probably gets 5. If your next patient is some robust gentleman weighing in at 320 pounds, well then of course he would get 10. If these medications are to be effective, they need to be given in advance. So typically you would prescribe the medication to be taken perhaps 30 minutes or an hour prior to hyperbaric therapy. That way we know there's adequate blood levels. Now, on a practical basis, this of course would preclude the patient from driving back and forth to the center. But again, I think all of you are familiar with ways to address those issues. The third drug that we could consider would be Thorazine. Thorazine also has a protective effect. I have not personally used Thorazine because it does have a number of other side effects, dystonic reactions and so on. But you should be aware of that. Now, the only other medication that I would add to this list would be Ativan. Ativan is also a benzodiazepine. It too can be very effective in the management and prevention of oxygen seizures. Now, in the dosing of Ativan, the typical dose will be 1 to 2 milligrams. Again, who gets 1, who gets 2 is largely a matter of clinical experience. A young individual, perhaps only 120 pounds, 130, would get 1 milligram. A larger patient might get 2 milligrams. Again, these need to be on board in advance. So I'd like to take a moment now to reflect on when to give these medications. You will not find any particular guidelines on this matter. Part of the reason is based on the infrequency of oxygen seizures. We learned earlier that at most the frequency rate is only 1 in 3,000 treatments. So if you were to say collect a reasonable sample size of maybe 30 or 40 cases of oxygen seizure, you would have to literally look at tens of thousands of individuals. So this is one of the reasons as you read textbooks and you go to national conferences, you may not necessarily find specific guidelines in this area. So again, you may say, but Dr. Bartlett, when exactly would you consider providing these medications? Well, let's say that you're taking a history on a patient and they have a seizure disorder. Clearly, it's a risk factor, and they're being managed with Dilantin. Dilantin is a very common anticonvulsant, but you'll notice Dilantin was not on that list of drugs that would prevent an oxygen seizure. This has actually been studied in animals where they've been given massive doses of Dilantin and there's been no change in seizure frequency. So for a patient like that, you may say, you know, I'm not only going to provide air brakes, but I'm also going to provide this patient with, say, 1 milligram of Ativan. Let's say that you're also taking a history on a gentleman. He is 65 years of age. He has a diabetic foot ulcer. As you take this history, you ask him, have you ever had any kind of injuries or trauma? And he says, well, yes, doctor, actually, when I was 18, I ran my motorcycle into a tree and they put a steel plate in my head. Well, again, that would be a person who has a head injury and they could be at increased risk. How about an elderly lady who comes into the hyperbaric unit all hunched over? Why is she all hunched over? Well, she has osteoporosis so severe her spine is collapsing under the weight of gravity. These are the kinds of patients who can actually crack ribs with something as simple as a sneeze or a cough. Do we want that person to have an oxygen seizure? Well, perhaps not. So again, we might consider a milligram of Ativan or 5 milligrams of Valium. And then there are some who simply are very anxious about hyperbaric therapy, and the family's anxious, and of course we worry about what would happen if they had a seizure. And the bottom line is there can be a variety of scenarios, from patients with trachs where there's concern of aspiration, where I think the patient and physician alike simply feel a little more comfortable having medications on board as opposed to relying on air brakes alone. So how should we go about managing oxygen toxicity? Well, certainly prevention is key. So we want to treat all fevers aggressively, providing Tylenol and Motrin, sometimes even considering some active cooling. That is to say, I've had patients with gas gangrene where I threw a cooling blanket on them for at least 15 to 20 minutes as we're getting them ready for treatment. Correction of acidosis and hypercapnia, avoiding potentiators here, vitamin E, and air brakes. And as you note at the bottom of the slide, for patients who have additional risk factors, you might consider additional medications. Most people tend to use Valium and Ativan because they're easy. We don't have to follow drug levels, and they usually don't interact much with other medications, whereas phenobarbital will perhaps interact with other drugs such as Coumadin. So what if they seize? And when are they most likely to seize? Are they most likely to seize in the first 2 minutes of treatment or in the last 2 minutes? Well, as we noted earlier, it's dose and duration. The longer you're exposed to oxygen, the greater the risk. So, if they seize, key concept, do not decompress. Why? Boyle's law. The seizing patient can have a partially closed larynx, which impedes the movement of gases. As the chamber pressure is dropping, the lungs could overexpand, possibly producing a barotraumatic event. So, key concept, wait until the seizure stops. How long will that take? At most a minute. You see, an oxygen seizure is actually treating the underlying physiology. The convulsing brain is consuming an enormous amount of oxygen, reducing the PO2, which brings the seizure to a halt. Sometimes people are asked, well, wouldn't you consider Ativan or Valium? Well, the reality is, even if you had an IV in, there's no nurse that could get to the Pyxis, crack open the medication, have it in the vein in less than 60 seconds. So if the patient has an oxygen seizure, I guess the next question is, well, what do we do next? Do we need to do a CAT scan, an EEG? Typically, standard of care for new onset seizure is to do those things. But that is not required in this particular case. Why? We understand the etiology of the seizure. Nonetheless, you must still keep practicing medicine. That is to say, if a patient has an oxygen seizure and you think there is a risk factor or a reason, then clearly work them up. So let me give you another one of these clinical correlations. Let's say that your patient is being treated for, let's say, its radiation injury. As you'll learn later, the typical pressure for that is 2.5 ATA. And it is a Wednesday and the staff calls you in to see the patient. The family's concerned because they have a bruise on their back. You come to examine the patient. You say, well, what happened? They say, well, they were in the shower on Sunday. They had a slip and fall. At the time, we didn't think it was a big deal. But now it's gotten all discolored. We're concerned. We wish that you would look at it. So we take a look at this. It has a very large bruise across the back. We palpate the ribs. They're not particularly tender. We get an x-ray just to be safe, and that comes back. So we reassure the patient that it's simply a large bruise and it will eventually clear in time. The very next day, this patient has an oxygen seizure. Well, the attending physician that day comes in to review the records. And what did they find? Well, this is an elderly individual. As they're flipping through the chart, they come to discover they're on Coumadin. Why? Well, about 2 months earlier, they had a DVT. Could an elderly patient on anticoagulants with a slip and fall in the shower have a subdural? Well, absolutely. That might be a reason to get a CAT scan. Let's say your patient did not have anticoagulants. Well, they've had cancer. Could this be a met to the head? Well, yes, it could. Another scenario where you might consider getting a CAT scan. But the key concept here is that the current standard of care doesn't require an obligatory or mandatory CAT scan for these patients. But again, keep in mind, you still have to keep practicing medicine. You still need to keep the brain in the loop. So to summarize here on this topic of oxygen toxicity, we have talked about a number of key concepts. We've talked about the mechanisms, how oxygen has a dark side. We've come to better appreciate oxygen-free radicals and also the various defenses the body has evolved to contain these. Things like superoxide dismutase, the cellular architecture, and so on. We've looked at the various forms of oxygen toxicity, CNS toxicity and pulmonary toxicity. Now, at this point, something that would be useful to put this in perspective is each and every day in practice, we are ever vigilant for CNS toxicity. Pulmonary toxicity, on the other hand, is really not a big concern. If you have a person coming out of the hyperbaric chamber with a cough, they are far more likely to have bronchitis or pneumonia than pulmonary toxicity. There are really only two scenarios where pulmonary toxicity should ever be considered. One is in the management of extreme anemia. As you will come to learn, these patients get extraordinary exposures to oxygen. And the other is decompression sickness. Again, they too have an inordinate exposure to oxygen. So on an everyday basis, CNS toxicity is always a possibility. Pulmonary toxicity is really not a big factor to concern yourself with except for the aforementioned conditions. We also talked about ocular changes. There can be a number of effects on the eye, and then we talked about risk factors, those specific things that could increase or decrease your risk for oxygen toxicity. Perhaps the most effective thing is air brakes. One final observation, for your patient who has oxygen seizure, what would be some of the next steps you would consider in terms of continued case management? Well, if there's no concern or you feel there's no need for further workup, CT, etc., most people would continue to provide hyperbaric therapy the next day. But typically what would be done would be a reduction in pressure. Who's most likely to have the seizures? As we've learned, those would be patients on protocols at 2.5 ATA and higher. Now I know that for most of you, you have yet to look at the protocols here in the curriculum. But what you'll come to learn is that basically patients can be divided into three broad categories. Those that are treated at 2 ATA, those that are treated at 2.5, and the third is at 3 ATA. So if a patient has problems at 2.5, most individuals would simply reduce pressure to 2. As you noted, 2 ATA is extremely safe. It is almost unheard of to have a CNS problem at 2 ATA. You could, of course, elect to continue air brakes at 2 ATA and perhaps even consider medications. So again, for your patients who have had a CNS event, at a minimum, I think you are obligated to at least alter your protocol in some way. Typically, most would reduce pressure